Dr. Neeraj for his talk on optimizing Toric IOL outcomes.
Good morning to all of you. So I'll be talking on optimizing toric IOL outcomes. At the outset, I thank AIOS and Rajasthan Ophthalmological Society for giving me this opportunity to talk on this topic. Now I'll be covering my talk under the following headings. We'll be briefly talking about pre-op considerations, patient selection, toric IOL power calculation, which is very important when we are optimizing this particular toric IOL implantation, pre-op and per-op tips, and tackling post-op surprises. Coming to pre-op considerations, we all know that 72% of the population, cataract population that is coming to us have more than 0.5 diopter astigmatism, 53% has more than 0.75 and 38% is more than 1%. So this 53% more than 0.75 diopters, this is the one which we have to hit. So once we hit this, we'll be getting very good visual outcomes. Little bit about anterior and posterior. We know the anterior corneal astigmatism, it is with the rule in the beginning and goes on with the age to against the rule, whereas posterior remains against the rule. So the importance of posterior corneal astigmatism is there, which I will be covering in my later slides. And the effect of ATR and oblique is more on the visual acuity as compared to the with the rule astigmatism. Now coming to patient selection, patients with total corneal astigmatism of 1 diopter or more than 0.75 diopter, especially when we are talking of premium IOLs like multifocal, trifocal, EDOF lenses, synergy and all, only regular astigmatism is corrected with toric IOLs. We have to keep this in mind. Exclude purely irregular and unstable astigmatism cases. Comprehensive ocular examination to rule out any comorbidity which can hamper post-op outcome. Ocular surface outcome workup. So the optimizing the ocular surface is again a very important point which we all have to consider, and it should be a routine part of toric IOL workup. In case of dry eye, treat for 2 weeks. If no improvement after 2 weeks, then avoid toric IOL implantation. So the poor candidates are irregular astigmatism, zonular instability, posterior capsular dehiscence, prior vitreoretinal procedures, glaucoma drainage surgical devices, poor pupillary dilatation, and corneal ectasia. Now, toric IOL power calculation, basically 2 parts. Axial length, we all know either ultrasonic or optical biometry. Nowadays, optical biometers are the best. Keratometry, important to determine the power and axis of toric IOL. So the magnitude and the direction, the axis, both are very important. So there are various methods for different principles like automated keratometry, placido disc and so on. The tips here is that determine the axis by topography, that is the axial map of the topography, and corneal power by auto K. In cases of mismatch, consider integrated K approach. Now what is integrated K approach is that we take 3 different machines, 3 different readings. If those readings are different, we put that into the Barrett's formula for integrated K and we get the vector meridian. And I'll tell you the results are that if we have this type of a picture, this type of condition when there are different readings in 3 different machines and we use this integrated K approach, we get more than 90% successful results. So the salient points are axis and power of the cornea, I have already discussed. The posterior corneal curvature is very important, and surgically induced astigmatism. So take multiple measurements, I have covered this. And in case of difficult cases like operated LASIK and all these type of cases, the best is aura. So we can use optive refractive analysis, and this is based on aphakic refraction during surgery. I think this is the best thing, especially what happened to Shah Rukh Khan. If this would have been used, this would have been avoided. K value we know if we just measure the anterior K, it overestimates with the rule and underestimates against the rule. And similarly, thus the toric IOL overcorrects with the rule astigmatism and undercorrects the against the rule astigmatism if only anterior corneal curvature is taken. So this I have already said that the anterior corneal curvature, this acts as a plus lens with the rule to against the rule, and posterior corneal curvature acts like a minus lens. So relying only on anterior corneal astigmatism alone leads to overcorrection in WTR and undercorrection in ATR. So how to measure PCA? So posterior corneal astigmatism can be directly measured if you have good equipments like Schimflug devices, Purkinje images, still scanning devices, and SSOCT based machines. Or we can use prediction formulas, that is the mathematical models like Abulafia-Koch formula or the online calculators or the Barrett-Toric calculator. So here I'll just like to add that in case you don't have access to the higher end machines for measuring PCA, better use the mathematical models in normal eyes, with non-operated eyes, non-refractive surgery done eyes, and they give very good results, especially with the newer IOL formulas that we have like Barrett and all. Now coming to SIA, now we all have to understand that SIA depends on surgeon to surgeon, incision size, incision location, superior or temporal, IOL size, corneal radius, corneal thickness and rigidity, and it is different for different surgeons. So prefer to take the centroid value, and it usually comes to 0.1 to 0.2 diopters. We used to take 0.5, but that is wrong. We used to get bad results with that. So what is a centroid value? Centroid value is basically a two-dimensional average of the magnitude and the direction. That is calculated by siacalculator.com. So, and then very important is that always keep your incision on the same axis. Like as a left-handed surgeon, I always keep it on 165 degrees. A right-handed can keep it on 10 or 15 degrees. That is up to you. But this you should always ensure. So coming to toric IOL alignment, their methods are manual marking. We all know bubble marker and pendulum marker. Then image guided systems are there, Varion and Callisto, and intraoperative abrometry, ORA I have already talked about. Coming to pre-op tips, pre-op patient counseling is important and address any unrealistic patient expectations. Always counsel for higher end lenses like multifocal, trifocal. Nowadays we have lenses like Pure C and all. We are getting very good results, though the near vision is not N6 with that. Evaluate the ocular surface. I have already discussed that. Rule out any ocular comorbidity which can cause undesired results. Check the pupillary dilatation, plan accordingly, and ensure accurate toric IOL calculation and toric marking. So this is the bubble marker that we are using. The bubble has to be in the center. So this is the marking how it should be. We should ensure that your 90, 0 and 180 marks are right up to the place. Don't hurry up here. This is a 5 degrees lens placement axis. So now once we have done that, the incision I make in such a way that my edge of my keratome is on the 0 or 180 degrees. So thus I land up in 165 degrees. So you need not mark 165 all the time, but when your edge is at the 0 degrees or 180 degrees, you will land up 165 degrees. Then always, that has I think gone by, we have to remove the visco from behind the lens, and I use the IA handpiece itself to dial the lens to the desired place. So remove viscoelastic thoroughly behind the lens, as I showed in the video, and because most IOLs rotate only clockwise, hence leave toric IOL 3 to 5 degrees anti-clockwise from desired axis before IA step, and final alignment to be done after wound hydration. Now a little word about tackling post-op surprise. You have taken care of all these things, but still you get post-op surprises. I think all will agree on that. So what are the potential causes of post-op surprises? We have to tackle here mainly the astigmatism surprises. Suppose we get a result of +2, -3 diopter cylinder, we can correct it. But if we get -2, -3 diopter spherical, -2 diopter cylindrical, that will not be corrected by dialing the lens, rotating the lens. So how to prevent these and how to fix these poor outcomes? Prevention is always better than cure. So tear film, I am again and again emphasizing on the tear film. So to optimize the toric IOL outcomes, we have to optimize the ocular surface. So, and importance of measurements in premium IOL. In our center, two optoms take independent readings, and then we match those readings, and accordingly we go accordingly. And importance of patient positioning. This is very important. If the patient's head is tilted when you are putting the patient is on the IOL Master 700, you will get bad results. So, and correct alignment. So this is what we have already, always an assistant who holds the head of the patient in such a way that the head is vertical. And then we have to know that in high myopes and high probes, the effective lens position that we have to understand. Average eye, the IOL plane to corneal plane, the power is 1.45, whereas highly hyperopic it is 1.2:1, very myopic it is 1.75:1. The prevention is always use higher end formulas like Barrett Toric calculator, which takes care of this ELP. Surgical mistakes, inadequate visco removal from behind the lens, and overinflated chamber. What happens if you have an overinflated chamber? The lens, it will be a larger bag, the lens can rotate immediately once the patient stands up from the table. And failure to take into account the surgically induced astigmatism. So every 1 degree, we know this, there is a 3.3% decrease, 33 on 10 degrees, and more than 30 degrees, the effect is lost. So summary of causes is pre-op measurement errors, incorrect marking of reference marks on the cornea, incorrect placement of the IOL, surgical mistakes, inadequate visco removal, and overinflated chamber, failure to take into the impact of SIA, and incorrect IOL power on the corneal plane. So how to tackle this? Evaluate on slit lamp. There has been a significant lens rotation, go in and rotate it. But when to rotate it? Usually the rotation occurs in first hour. So we don't discharge the patient immediately. Toric patients, we don't put a pupillary constrictor on the table. After 1.5 to 2 hours, we see the patient. If there is a rotation, my point is we don't take up immediately for re-rotation. Because if whatever is the cause of rotation, it will again happen. So we need to wait for 1 to 1 week preferably. Before 2 weeks, still some fibrosis has occurred, so that when you rotate, it will not rotate again. And how to calculate the axis? We have ASCRS online tools, and or we can go to astigmatismfix.com. These are the tables where you can put. Surgical intervention I have already talked about. And if the patient needs an IOL of different refractive error, the surgeon should act promptly. Here you need not wait for 1 to 2 weeks. You can replace the IOL earlier if it is the spherical power mistake. There is a small video how we basically do the rotation. Yeah, it's done. It's done. So other options are excimer laser and IOL exchange, glasses contacts, the ORA I have talked about. Thank you.
Thank you, Dr. Neeraj, for a very comprehensive presentation. One observation I like to share with the house is, I have seen most leading phaco surgeons little apprehensive or little more concerned when they are doing a toric IOL. They will post such cases on the top priority of their operation list, then they will perform the conventional IOS. And I would like to know from Dr. Jhala, his comment, as Dr. Neeraj has rightly emphasized on evaluation of posterior corneal astigmatism. This has come up in last few years. We were not doing it in yesteryears. So how it has made a dent in the overall outcome of the surgery?
So we have now ARGOS system and video on calculator for this, and what I want to emphasize, I don't have much experience on the posterior astigmatism, but one thing I want to emphasize is that we are concentrating on 1 diopter and above, but there are certain patients who are there between 0.7 to 0.9 degree of astigmatism. So in our Argos calculator and Virion system, there are these such patient may also need toric IOL. So we neglect this patient, but there is a model in Alcon. Alcon have come up with a model, T2 model, so that should also be considered. So to get better post-operative outcomes.
It is especially important if we plant multifocal or trifocal lenses with 0.9 or 1 diopter astigmatism. At that cases, in that cases, we should plant toric multifocal or toric trifocals.
Dr. Arun, would you like to share with a very short comment?
I very much agree with Dr. Gulam that now if you're planning for an emetropia for the patient, even if there's a 0.75 cylinder or even 1 cylinder, we usually, and the patient is going for an EDOF or a multifocal IOL, we'll go in for a toric. Earlier, our cutoff was say maybe 1 cylinder, 1.25 cylinder, but these days with good results, surgical outcomes, and good predictable outcomes, we even go with 0.75. And if there's less than 0.75, we try and adjust with the site of the incision.
Thank you,
One
Dr.
point I
Neeraj.
like to add here, in high myopes, in very high myopes, usually some people say that you put a CTR. So usually CTR doesn't help as far as the rotation of the IOL is concerned. It helps to stabilize the bag. But if you are putting a CTR to stabilize the rotation, it doesn't help.
What's last question? What is your experience with toric IOL in irregular astigmatism patient?
See, that is a talk altogether different. It is a different talk, but what I'll say here is that in post-RK patients or where the astigmatism is stable, there it definitely helps and gives much better results as putting a normal lens.
lens. Right.
Thank you, Dr. Neeraj, once again.